So how's it going so far? Is this easier or harder than being on call? It's different, right? It kind of takes you back to your first year med school days where you're workshopping and lectures and so forth. So it's pretty...
There's more coffee drunk, but there's more time to go get coffee.
That is true. So there's a balance, right? Yeah. And some work in the evenings, I know. So great. So for the next hour, 2 hours plus will be what we call search and learn. So I think you probably gave you a bit of an orientation at the beginning or half an hour ago or so, finding topics and doing a little presentation at the end. What I wanted to do is really, it's very, very brief. I'm not going to talk for more than 5 or 10 minutes, then we can get started. And I'll tell you kind of how I formatted the afternoon a little bit. So translating research to patients, that's really what this is about, is kind of finding a topic, doing literature search on it, and making it practical. We talk a lot to each other. We talk a lot to attendings, other residents, et cetera. But really, at the end of the day, applying knowledge to our patient care, to clinical practice, and communicating the results of our literature search and this new knowledge to parents and we'll use the word term family because obviously patients for the right age, but parents especially, it's a very special part of pediatrics as well too. So we'll just kind of go through. I only have a few slides. Just wanted to say, I was told to put in a little bit about myself, and I just basically don't have that much interesting. So quite boring, really. But 3 things that you probably didn't know about me. And as R1, you could probably, until we work together in a merger on the CTUs, then we learn a lot about each other. But as R1, it's less likely. I threw the javelin in university, which is kind of odd, but went to nationals in the U.S. with that, so that was a long, long time ago, and I'm finally getting surgery in March on a shoulder injury that I suffered my senior year of university. It's amazing how you put things off until they really start to annoy you, and 25 years later, an MRI looks pretty scary. Anyway, so all that to say, better late than never. I played the trumpet, and I don't like mushrooms. Those are the 3 things that I could find that was a little bit about myself that may or may not be interesting. So Celia also wanted to say, what's my interest in academic skills? And for those of you who know me and interviewed together, of course, I'm not a researcher. I've done research. I've done some lab research, and I enjoyed it, but I'm not primarily a researcher. I tend to focus clinical, practical. I wanted to see how we can actually make this real, make this efficient, translate it into real, everyday life. So how are we going to format today? A really, really quick overview of knowledge translation. I'm going to give you some tips on communication of knowledge to patients and families. And then we're going to do the first half of the presentation. I don't know if we'll probably just accept volunteers or go around the room. Or is there an assignment as to what order you're going to go in? So we can do it however we want. Perfect. So your presentation will be about 5 minutes. At the end of that presentation, I will give you a warning about the 4-minute mark, just so I have to grab my phone so I can time myself. The 4-minute mark, just so you kind of know to wrap it up. And then there'll be about a 3-minute time to debrief. So we're going to let Candace debrief, again from a parent point of view, how she felt that went, and some things that went well, and some things that were a little bit maybe confusing, if any. And then I'm going to pick 2 of you to also give feedback, both verbal feedback and written feedback. Now, do you have you have some, okay, I've got tons as well too. So each of you has 2 or so?
Just 1.
Oh, just 1? Okay.
No, I was just going to test it.
Okay. There's plenty here. There's plenty here. Is everyone who is 1? 2.
I use 1 for note taking.
Okay. Okay, yeah. So at the end of the presentation, I'll have you all pay attention, and then we'll pick 2 people to give some verbal feedback, but also some written feedback as well, and I'll do the same. We're going to do about half the presentation, so there's 11 of you. We'll do 6 presentations or so. Then we'll have a kind of a group debrief. We'll talk about how those went, what were the highlights or the biggest things in terms of what you watched in the presentations that worked well, what didn't work well. After that, we can have a little bit of a break if we need to for a long afternoon. And then when we come back from break, we'll do a video. This is a video that some of you may have seen. I'm going to keep it a little bit of a surprise at this point, but it's just a short 4-minute video that will emphasize a little on, it's a reminder of who we're talking to, right? That it's not just a brick wall. It's someone with feelings, emotions, and how they receive it is so very important. Then we'll do the second half of the presentation, and at the end have a debrief, and hopefully have some teaching points to take home. So what is knowledge translation? There's a long, complicated definition of that. So we'll just kind of break it down just as a review. Just a second here, sorry. I realized that I don't have the presenter view, so I don't have any of my notes. So I can either wing it, which would actually be kind of an interesting thing. Okay, so here we go. So synthesis. So this is the easy part, right? It's not easy to get new knowledge, but it's easy to define it. This is what happens in the lab. This is what happens by posing hypotheses, answering questions, trying to figure out, is this working? Is this not working? And so forth. So, maybe not, easy in real life. But as my daughter says, easy peasy lemon squeezy in terms of finding it, right? We just need to get more knowledge. And that really happens to a large degree outside the clinical scenario, but really not so much the focus of today. So dissemination. So these are the questions that you need to ask. What audiences are we trying to reach? From a KT point of view, that can be very broad, right? If you publish something, you're going to publish it in the New England Journal of Medicine. That's going to get you a certain audience. You might publish some, more esoteric biomedical engineering in a different journal that will reach other biomedical engineers, for example. So really gauging your audience is really important and how we reach them. And then I like the word exchange in this definition as well, because it's more than a one-way street, and we'll focus on that a little bit today. So exchange really implies a kind of a mutual sharing of knowledge, right? When we talk about closed-loop communications in the setting of code and other things, is the person that you're communicating with or to, are they understanding what you said? At the end of the day, it's much more important what they understood than what you said. If you say something and they didn't understand it, there was no point in saying it. It's just talk. And then obviously you have to apply it. So it must be applied carefully. So in terms of the goals of knowledge translation, improving health, providing more effective health care, et cetera, I think the rest of that definition we all agree with. I wanted to show you just one actually, before I was going to show you a busy slide, but before I get to the busy slide, again, trying to simplify things, really, if you kind of do this as define knowledge translation as getting the right information to the right people at the right time and in the right format. So those are all challenges which may not be as easy to plan. So here's my busy slide. Just because we do talk about knowledge translation, I have to show this slide. I'm not going to do it any more in depth than that. But really kind of talking about, have you guys seen this slide before? This is something that's come up, or something similar. So really talking about kind of the knowledge inquiry, synthesis, kind of products, tools, identifying the issue at hand, taking the knowledge at hand and applying it to kind of in the local context, assessing barriers, selecting interventions, monitoring the use, evaluating outcomes, and then sustaining the knowledge use. And again, that's kind of a very big cycle. And certainly summarizes knowledge translation not only for us as clinicians with patients, but kind of on the broader, this could apply to health systems, could apply to policymakers, et cetera. And really, I think it's what a label of what we've been doing all along, but this makes it much more intentional. So moving on quickly, just into the goals of communication. And again, in the model of a clinician explaining something to a parent, like you have your topics that you're now having to explain. Today it's one-to-one communication. There's really kind of two goals of communication, right? There's a cognitive goal, there's a need to know and understand, right? The parent needs to know and understand what you're talking about. They may not know that they need to know, but you know that they need to know and understand sometimes, right? So you need to communicate that as well. But just as important, and maybe even more important, is that they need to feel known and understood as well. Again, that's that mutual exchange of information. We kind of talk about, patients won't know how much, they don't care how much you know until they know how much you care, and you probably have heard that before. And really, those are the goals. The example that I give of the patient point of view is when I was 16 weeks pregnant in a foreign country, and showed up at the emergency room with some acute bleeding. And the very first thing, she introduced herself and said, "Before we do any details, I'm just going to pull out my Doppler," and heard the baby's heartbeat. I knew at that moment that she cared. She got me. I wasn't worried about me. I wasn't worried about bleeding to death. I was worried about the baby. And she's like, okay, now that we've got that taken care of, we'll work on the rest of it. I've never felt so known and understood as in that moment as a patient. So I do like to share that, and we probably have similar stories that we know as well too. So what are some barriers to communication? And you have to gauge emotional readiness, language communication ability, intellectual ability as well. What terms are you going to use? It is helpful to know if you're communicating to parents or medical professionals, because we might use different terms and have a different approach to it. Patient worldview and culture is important. Information overload. Poor organization can be something as well too, is we need to know how we're going to present it and what we're going to present before we walk into the room and be able to modulate that. No, almost done. So setting the stage, asking how parents would like to learn. Do they like to discuss it verbally? Would they like to have some reading material first to review what you're going to talk about? To talk about rapport building, interest, empathy, reassurance, legitimization of their concerns. Gauging understanding, a very good way of approaching it is so we're here to talk about problem X. I said, so what's your understanding of where things are at with your son or daughter? What's your understanding thus far? And you'll be amazed with that opening statement, if you haven't already used it, what they come back. Either people who you don't think understand have a much better understanding, but often it's vice versa as well. And you have to start at a different level. Again, taking cues from the parents. What are they able to accept, and what are they actually willing to hear at this point? You may have planned an hour-long conversation, but maybe it's going to last 10 minutes because it's clear that the parents are not at the point to hear what you need to say. Being conscious of nonverbal communication, and I have a slide that talks about what I mean by SOLAR. And then partnership building. Again, listening to the family concerns, opinions, and building and explaining expectations. So what's SOLAR? Anyone heard of SOLAR before? This was back when I took a counseling course, way back when. I found it actually very helpful. And this is helpful kind of in nonverbal communication, not just with patients, but with partners and family members as well, too. So what do we need to do? We need to sit. Is it less threatening to sit or to stand? Okay, these are kind of rhetorical. Sitting is better, right? Open or closed, right? Leaning forward or leaning back. Eye contact. And one thing when we give lectures, and you guys have all done that as well too, is looking around the room. And so far, I hope I've maintained eye contact with all of you at least once or twice just in the last few minutes as well too, because that makes you you're not just a number, you're not just a body. Again, you're understood. So maintaining that eye contact, even when it's uncomfortable, even if you want to look away. It's not true for me right now, okay? But there are conversations where it's hard to maintain eye contact. But how important is that connection, right? I get you. I want you to get me. I want to have that relationship. And then relax again, if you're all tight. Sometimes in those things, just kind of going through that checklist can be very helpful. So last slide before we start the presentation. So here are the questions that we're going to kind of ask of these presentations. And notice that there are three different questions that I think are equally important. One is the kind of delivery of information. Is it accurate and organized? One is was there a demonstration of that interpersonal sensitivity? Was there kind of an acknowledgement of what the parent might be going through, what the parent might need to know? And then was there evidence of partnership building? So there are just some buzzwords to think about when we're looking at the presentation. And let's practice. Any questions about that? Probably the things that you've heard before, but I really wanted just to take that twist on this. Okay, so let's do this. So I'm actually going to have you sit here, and then whoever's presenting, you can choose to sit or not. I won't comment. But that way, if you're right there, you can kind of talk to the parent, of course, but obviously the rest of us can see you as well. And this is not meant to be a time of criticism by any means, but time to be honest. There's so many times where we do things, nonverbal mannerisms that we don't recognize until someone highlights it to us. I was just telling Celia about a similar session I had when I was a medical student. This was back in 1993, so it's been a while, but it stuck with me, and that it was something similar to this on Breaking Bad News. And I was told at the end of my breaking bad news, whatever news I was breaking to this patient, or this pretend patient, I was told that I smiled too much. And I realize I do that. When I get uncomfortable, I smile. Because I want it to be okay. I want it to be okay. But if you're breaking bad news, maybe that's not the time to smile. Because that can be interpreted as you're being funny or something like that. So anyway, just some examples to think about. So who wants to be first?
Is this okay? Because I know you wanted the computer area. Is that okay if Candace is there? Is that okay like that? So that,
Okay. Yeah.
or turn that differently? I want it to be relatively close to Candace. Do you want some space for people? We're good?
I have one question then.
Yeah.
I'm kind of confused with the context of the parent. Like, am I talking to this parent as if their child has something to do with what I taught them?
Yes.
That's what I was thinking.
Yeah. Now,
So I
Candace.
almost feel like you have to set the scene every time you tell kids to do
And
it.
it's okay, so because Karen has the list for each of, and can say, this is what the topic is, if you want to, you can start with that
Sorry, I
topic.
just wanted to.
Yeah, and Candace, I mean, she's not going to volunteer information, but go ahead and as if it were a parent, what we're looking for, do that. I'll give you a hint. Pause and say, how is it going so far? Is this making sense? Do you have any questions? This is kind of what we're looking for, as well as presenting it. Does that help?
Yeah, it does.
Okay, who wants to be first?
It doesn't matter.
Okay, Laura, did I see a little hand?
No, go for it.
Okay. Let's see, grab my phone real quick so I can do the timer going.
Oh, the clock's right across the screen.
She can adjust you.
Play or do you want to?
Oh, I don't.
Okay, go ahead.
So I'm first going to start with a recap of what you've been going through for the past couple of days. I understand that your son came in with a fever and he was seizing. And then his personality kind of changed and he's on and off, sleeping and awake, and kind of behavior is different. Is that right at home? Yes. So when that happens and he's having new seizures, he never had seizures before is what I understood. One of the things that we are worried about is encephalitis, so inflammation of the brain itself. And there are two main causes in kids that we can actually treat. So one of the things that we're concerned about, it could be a virus. So a virus going into the brain cells and kind of, when they replicate, the brain cells break. And that affects our brain. And the other cause is more autoimmune. So their own antibodies are attacking parts of our brain. So our brain works by firing electrical activity. So like the power cords, they're surrounded by plastic to insulate it. Our brain cells are surrounded by what we call myelin. And that helps our brain conduct electricity more efficiently. So sometimes the antibodies can attack that myelin, and that will affect the way our brain works. So there's the autoimmune cause and the viral cause. Are we on the same page so far? Okay. It explains a lot of the changes you see. So it mainly affects the frontal lobe, which is in the front, responsible for our personalities. And that's what you've been seeing, some changes in his behavior. And other parts that some of the viruses can affect is the temporal lobe. And that's what happens when it's affected, you start to see seizures. And that explains the physiology of why things happen or why you see the changes. So in order to treat the virus, one of the viruses we can treat is HSV, or herpes simplex virus. And we treat this with a medication called acyclovir. It's an antiviral medication. But for the autoimmune cause, the other cause that we were looking at, one of the treatments we use is steroids. So right now there's a little bit of controversy. So people, scientists believe that steroids, what they actually do is suppress our immune system. And that's how they work. So one concern is that if we use steroids in the event that it is a viral cause, is that our body can't fight it off, and the virus will replicate uncontrolled. Is one of the worries that people have. But at the same time, we kind of need to treat, if it's the other cause, the autoimmune cause, then we need to treat it with steroids. Are you following so far with that too? Okay. So right now we don't know which cause it is. Yeah, he just came to hospital. We did our lumbar puncture, so we took some fluid, but it takes time for analysis to happen. But before we can find the true cause, we need to start treating because he's seizing and his behaviors are changing rapidly. So what I looked into the research is that we have been treating him for viral cause already. For the past 2 days, we've given him the acyclovir that we talked about, and he's been not really responding too well to it. So now we're starting to worry that it's the autoimmune cause. So we're considering starting steroids. And we discussed briefly about the controversy already, that it might suppress our immune system. But when I looked into some of the experiments and some of the case reports, it actually might be beneficial in starting steroids for viral causes as well. So viruses cause damage by breaking or replicating and breaking the brain cells. And the second part is the inflammation that it causes. So our own immune system, when it fights off it, when it attacks it, also affects it as well. So there's some research that if you delay 3 days so that your immune system can still fight off the virus for the first 3 days, and then start steroids to suppress the immune response itself, then it might actually have better outcomes. And some of the kids are found to have less decreased levels of consciousness, better cognition, and better motor function at the end if we do start steroids later on when kids are coming with a viral cause for encephalitis. So if you're okay with that, I think we're considering starting a steroid now to treat for both the delayed effects of the viral encephalitis, as well as just in case he has the autoimmune cause of encephalitis, then we can treat that as well.
Okay, 5 minutes. Okay, time for feedback in this one. Can I let you start? Or do we have a resident start? That's fine. I'm just going to pick on people. I'll pick on James.
Okay, sure. I thought you related well to Candace. I thought you had like an appropriate tone of voice, and I thought you came across as warm and knowledgeable, which was really good. It sounded like you had, when you were explaining, it sounded like you had good rationale for what you wanted to do, and you were very thorough when you explained it. I think at the beginning, you were really good about checking in and making sure that Candace understood where you were coming from. But as it got a little bit more in depth and a little bit more technical, I thought you went a little bit longer without checking in. And I maybe would have liked to see, when you were talking about some of the more technical stuff and like explaining why you were doing certain things, maybe once you explained your like scientific rationale, translating that into like layman's term as a way of like recapping and asking, did that make sense? Like, we're trying to do this as your like sort of like your simple like chunk way of understanding it, and then asking if that makes sense. So you're showing Candace that you have a reason for why you're doing this, and then explaining what that is going to look like, and then asking if that still made sense. Would be the only feedback, because I think you tried to check in and see how she was doing, and you have a topic that's not something that most people would come into contact with in their like day-to-day life. So just like really breaking it down, I think would have been really useful. That over. It's good.
How about you, Linda?
So I really like your manner. It's just like very reassuring, very gentle. Like if this is a mom of like kid with like encephalitis, understandably she'll be like very anxious and stuff. So I like the way you like gives the manner in which you talk to her, and in terms of things to like modify, like I guess it depends on the education level of the parents as well. Because sometimes it could get a little bit too technical in terms of like explaining how even like explaining how like a steroid would work and like information and like stuff. So sometimes maybe like explaining to that level of detail wouldn't be necessary depending on, I guess, like how much the parents are interested in.
So, James and Linda, I'll have you fill out the forms for that. You're welcome. Any other thoughts?
You did great for communication. Eye contact was good. Explaining was good. Very technical at the beginning, so throughout the whole thing. So, but didn't say what it was right when you started until a little bit later. So I guess if I had already been told that, it wouldn't have made a big deal. But just saying, come in and this is what we found, so I don't know. It's just
So it's hard to be the first one. We'll take a little longer. I thought that was really good feedback. Overall, I thought you did a really nice job. I really liked your eye contact. I mean, I really got the sense that you were wanting to give information in a way that the parent could understand. And you had obviously done your homework, your 30 minutes of homework, in terms of preparing for this and trying to kind of keep in mind everything like that too. I think some organization tips that might help us as well is similar to when you're presenting a history and physical. That's easy. We've practiced it. You're going to start with chief complaint, and then you're going to do the history, and then you're going to do the past medical history, then you're going to do the surgical history, then you're going to do this and this. And so basically in our mind, that's organized. We know that. As attending, we know that. Well, that's how you're going to present to us as well, because we can follow. We've been there. A parent doesn't know what they're in for. So I'm setting the structure. So this is what we're going to do today. We said first we're just going to do 2 goals for today. The first goal is to talk about your son and what we think is going on. Make sure that everyone has a good understanding that we're all on the same page as to what we think is going on. Then we're going to transition. The second focus of today is to transition to talk about treatment plans and some options that we have. Does that sound okay to you? And of course it will, but now you just set the stage of what's going to happen here and here. And then to kind of take a break, okay, now you understand what's going on. Okay, so now let's move to the second part of our conversation. Let's talk about treatment plans. And there are some choices that we have to make with treatment plans because this is a relatively uncommon problem. And there's discussion. I'd probably avoid the word controversy because no one likes to bring it as a controversy. There's some different opinions about how to manage it and so forth. So that would be my one very small thing. And I think the other thing is that we also, so easy to use words like lumbar puncture and myelin and autoimmune, and those are words to us that just are the same as, the color green, and, those are words that just fall off our tongue. But again, to the parents, kind of keeping that balance of, do we use a word and then define it, as you did, like the myelin? Do we use that word, or do we just simply say, there's something that goes outside the nerves to protect them, and these antibodies attack that something? Do we even confuse them with the word myelin? Some parents, you would use it. Some parents you wouldn't. So again, that gives some. Overall, nice job. Okay, that was a little bit longer debrief, but we'll go from there. That was lovely job. Okay, who wants to be next?
I guess you're looking right at me.
Yeah, if you're looking like this, then I do that in emergency a lot. If I need something, like I look around for a nurse, and the nurses know to not meet my eye because I'm going to ask them to do something for me. Oh, okay. So, go ahead and start.
All right. Hi, my name is Duncan. Very nice to meet you. So I hear you're coming in to talk to me, and I apologize if I'm looking at my computer when I'm just referring to my notes. So I hear you coming in to talk about your son or daughter playing youth sports and concussions. So you wanted me to kind of just tell you what the incidents are and some general advice. So what kind of is your general worry about concussions in your kids?
Not being able to get out of a concussion. Sure.
Perfect. So those are all great, really worries. And whenever anyone suffers any sort of concussion or brain injury, you're always worried about those things, about how they're going to recover after. Will they come back the same person? And will it can be a consistency? And then ideally, you were asking, generally for me, what sports are kind of greater risk than other risk. So when I did some research for you, the main thing that I found is that for any sport, regardless if it's badminton to hockey, there's always a risk of concussion. There's always a background risk because you never know what can happen. And then I know we were talking about, say, your son, about hockey and football specifically. So from what I found a really good article that reviewed the research over the last 25 years, so really good number of sample, and it looked at all the different sports. And it showed that for hockey and football, both hockey and football were the number 2 and the number 3 list for the highest concussion rates with sports for these kids. So the biggest thing what does that mean to you? I don't think it means that your son doesn't need to play football or hockey, but what it does mean is that you should be more aware about certain signs or symptoms, that if he does, say, take a rough tackle or a rough hit in a hockey game, just be more aware of it, and also make sure that all the equipment that he's using is up to date, that you have that, and as well as checking in with me consistent, however much you like, about if you're ever worried about that, or asking me to look into more research about protective equipment, and I can reach out to colleagues and see if there's anything new. Does that make sense? Do you have any other questions? Don't think so. Mine was shorter than 5 minutes.
That's okay. Well, that would have time to debrief. Did I hear something over there?
Oh, no, I was razzing him. Sorry.
Oh, no. That's perfectly fine, So, and I think by the time we get to the 11th presentation, you guys will be kind of on a roll in terms of being able to practice this and so forth. So I think that's great. Let's do some debriefing.
Sure. So I think there's no question that you came to the table, both to confirm what you were going to talk with her about, which in this scenario particularly needed to do, but also using generally terms that were knowledgeable to her and such, except for you used sample. You said sample at one time, which out of context may or may not mean anything to a parent. I think in general, when you speak, you give off the impression of caring and being interested, and I think that's true in lots of things. But I also think sometimes the terminology, and not necessarily kindness, but saying like, I went and did this for you, or I know for some people that might be a little overwhelming, or someone might be like, well, that's your job, or I don't know the terminology, but I think knowing your audience there might be something. And in a topic like this, maybe having some resources that they can take away with them isn't what we were told to do, but I think in particular, concussion or other places to go and talk about this, because realistically you offered to go and do a lot of research for her, which maybe you really would in real life, but I don't know if you'd have enough time to always look up what equipment should be for what and like those kinds of things. So just maybe making realistic follow-up plans. That said, I know you were shorter than you intended, but there's also no point in speaking when there's nothing more to say. So I'm gonna stop there. I have nothing else to add.
It's okay. You want to get your turn.
I thought it was really good. I liked how you kind of came to the table and kind of set the stage for what you wanted to talk about. Ask kind of what her concerns were. It was really great. I think your body language and tone and everything was good. One thing that I would have done maybe to improve, you had talked to her about what you need to be aware of is the symptoms of concussion and just be aware of those. Maybe actually teaching her, these are the symptoms of concussion, this is when you should be worried, this is when you should come to see me, or this is when you should take your kid to the ER type thing would have been useful for her to know. So yeah, overall, well done.
But that's not necessarily a bad thing. As a parent who likes to be proactive with their children, having like Suzanne said, the researcher pamphlets or whatever available so that I can go look it up myself, it is a good thing. But yeah, eye contact, body language.
Yeah, no, I agree. So, and usually more the incidence of discussion.
Yeah, so
incidence of concussion was your name. Okay. What was your topic? So, okay. Yeah, no, I thought that was good. Casual. I echo some of the comments about I did some research for you, and you did for probably a little bit inferential, like it is a little bit too much. Yeah. What you may want to do is, so, I wanted, myself, I always like to learn myself as well too, so I looked up some articles, wanted to get myself up to date and up to speed on the most current research out there for concussions, and I'd like to share that with you if that's okay, something like that. I thought it was good. The other thing I would say, if you have the time, use it, right? And sometimes it's tempting to kind of rush things through. Sometimes we are rushed in emergencies, sometimes, especially from my background, you're very conscious of the 26 patients in the waiting room and the fact that you kind of need to get a move on. Keep in mind that the patient in front of you is the most important patient. Whoever that patient might be, that might be the patient from the trauma bay, that might be the patient in room 7 with abdominal pain for 3 months and so forth. So I'll be being conscious of the other barriers. And for you, for example, you had 5 minutes. So what you could have done in those 5 minutes, and this is what's always hard to anticipate how conversations are going to go, maybe define concussion, just to make sure you're on the same page of what a concussion means and how we grade concussion, the fact that we no longer grade concussion, kind of a return to play guidelines. Maybe not as applicable in this particular situation because you weren't being asked a specific question by a parent, but I thought overall good. Definitely very relaxed, very nice one-on-one conversation. I really felt that the parent was comfortable asking you questions if she had any, or just kind of interrupting. Good check-ins. So, thank you. Awesome. Awesome. Who wants to be next? Rob's ready.
Me too, yeah. Higher standard.
What's that?
The higher standard.
Yeah, going the first is actually easier in some ways. Okay. Robin, go ahead and start.
Hi, Candace. My name's Robin. I'm the resident on call tonight. The nurses let me know that you had some questions about the sugar solution for your baby. Did you have any specific question about it, or were you just kind of more curious about what it is and why we do it?
Sure.
So it's actually a really great question, and it's kind of something we always just do, and I actually didn't know a lot of the background as to why we do it, so I did take a little bit of time before I came to see you and just did kind of a quick search through some of the databases that we routinely use. And it's actually very well studied. I was surprised at how much study goes on with something as simple as sugar. So there's over 100 studies that have happened over the past 20 plus years. And so what we're talking about is a sucrose solution, which is really just table sugar, the sugar that you or I would put in our coffee or tea, and dissolved into water. And what we do is we give it to babies before they're going to get maybe a little bit of a painful procedure. So the one that we're kind of talking about here is getting the heel stick for blood work. And that's probably the most common thing that it's been studied in, but they have looked at stuff like circumcision as well. And they've looked at it because there's all these studies, there's a wealth of information on it, but it is generally quite effective. Does that make sense so far? Yeah, did you have any questions about the solution or anything like that, of how we administer it? Sure. So usually what we do is we give babies either dip their soother in a little bit of the solution or just give them a little bit in a syringe. And that we, depending on how long we have and stuff, we usually wait till about a minute just to let them kind of get that in their mouth and get it kind of acting, I guess you would say. And then we kind of do the painful procedure. So in this case, we're talking about the heel stick for the blood work. And then we don't entirely know why it works. Some people have looked at a little bit of that. It does seem like the comfort of having something in their mouth is helpful, but also maybe there's an element of like actually having something sweet being helpful as well. The way that I kind of think of it is if you were ever to go get our blood taken and somebody gave us a lollipop to suck on, it would be a little bit distracting and you might notice less that they're giving you a poke. So there has been research that looks at different methods. So giving them nothing, giving them a soother with just some water on it, giving them a soother with the sucrose or the sugar solution on it, and that seems to be the most effective when you're comparing them. There is some studies looking at that versus letting babies breastfeed, and not really sure about it. No good evidence, I guess you could say. Does that all make sense? Did you have any other concerns about?
I was going to ask, well, could you not just put baby on breast then?
Yeah.
So that you're not giving them sugar.
Yeah. So I think for something like this, when we're talking about a heel poke, that's a reasonable thing to do. Part of that is trying to line up having the lab come up while baby's wanting to eat. So sometimes we try that, and if they're not really interested in the breast, we'll go the sugar route as kind of an alternative. For some things, if you're talking about doing something that's a little bit more invasive or you need kind of more of a clean field, it's hard to do that when baby's on the breast. And so that's kind of why I think some of that research into the sugar has been ongoing when we know there's good evidence for breast as well.
1 minute.
Do you have any other questions or concerns? Okay, fine. You know where to find me.
Great. Let's do some feedback on that. That's what I'll put you on the spot again.
Sounds good. I thought we'll go with like positive. So body language I thought was very good. It was very open. The store or whatever the acronym was. Very good. As well as you checked in a couple times and see if you have any questions. And then I thought your ability to answer follow-up questions is always important. So it shows like level of knowledge. So I thought that was good. And then she like threw in the thing of like being on the breast. Not that you were able to do that and say yes in some certain things, but no, not just saying, oh yes, of course. It was able to kind of set the stage for any further things. And your pace of voice I really liked. It wasn't like, I feel as I talk too fast as I'm doing right now. Go type of mentality. You had a really nice, calm pace to your voice, which was really good. And for areas where I don't really see any currently. Like, you're a really good chance.
I have a really small, like very small. Kind of like the smiling a lot. Sometimes you giggle, and depending on who you're speaking with, that could be misinterpreted as like that's not as good a thing, or that's not the right thing, or this is crazy I'm saying it, but I'm proposing it to you something to do, which if you're suggesting it as an option, can take away from that really valid suggestion.
That's right.
But that's...
I'm sure if it was more serious.
Yeah. Probably more a nerves thing.
Yeah, it kind of goes again to that smiling when you're breaking bad news, and we don't realize that we do it, but we're kind of more on the spot. I think it's easier with practice as well. Candace. No, I thought you did a really nice job too, and I thought establishing rapport, getting down there, getting on her level, and just setting off the stage well, and kind of acknowledging that we use it, but I wasn't sure myself again what the research was behind it. So I really wanted to learn about myself, and just by doing that, kind of puts you on her playing field, right? I want to come in and tell you all about this because you don't know anything and I know everything. Again, that's not the message that we're trying to give, but it's a bit more hierarchical, right? I wasn't sure either, so I looked at this. Let me share with you what I learned because this is really cool. That already kind of, not making the mom feel stupid at all because a lot of us don't dig deeper. Kind of in the heat of the moment, but it was good. It was good that you did. The only tiny suggestion that I would have, and again, we don't know what mom's concerns were, but just maybe emphasizing kind of what's in the sugar solution, that it really is water, sugar, and something to make it purple, I think, right? The ones that we use are purple. So I don't know if that was maybe one of her concerns, again, we don't know, but that may be something to but overall, I really like the ending. You know where to find it. Make it available for follow-up as well, too, to say this conversation isn't over just because I'm getting up and walking away. And we can talk about this more. And sometimes that works on the CTUs. Doesn't work as much in an emergency if you're sending them home, but kind of directing them to resources. If you have further questions, it's a great discussion to have with your family doctor or your pediatrician. And there's good websites to access and things like that, too. So, Nice job, thanks. Okay, who wants to be next? Jesse?
I can be like tired.
You're gonna grow a foot before you get to the bar. I'll give you some high jump.
Javelin, not
This is not shot put.
I should have brought mine, right?
Is that going to take you on a shot then? No, I was just going to say they don't have meter sticks anymore.
Ready? Go ahead.
All right, hi, I'm Jessie. I'm one of residents in the clinic today. And I heard that you had some questions that had come up with you and your child with regards to medical assistance in dying. And I know it's been quite a hot topic on the news as of late, and where that relates to children and your children in particular, and that your child had been asking questions about that. And so I just wanted to kind of come in and have that discussion with you. And I just want to say off the bat is that I think it is a really broad topic, and I don't think that in our 5-minute discussion we're at all going to be able to cover everything that I would want to talk about with you. So I want to make sure that that I start with that, and that if you want to follow up and have a little bit more time to discuss, that can be set up in the future. So is there anything in particular that you wanted to make sure that we get to today with regards to the topic? Okay, so maybe we'll just start with like kind of a broad overview of like recent news and opinions, and then kind of maybe get into some more of like the research that is surrounding it, and maybe I can help you with some of that stuff. So I'm not sure if you are aware of this, but medical assistance in dying has been legal in Canada for just over a year now. It was legalized in June of 2016. But that, the way that the bill was passed is that it excludes minors. So as of now, pediatric patients as a whole are not eligible for medical assistance in dying. And there are a lot of different opinions as to whether or not that should be something in the future that could be added, or whether that's just not a no-go area. And I think that the more and more you research, the more and more opinions you'll find. And I think even for myself, when I was searching, everyone seems to have an opinion. And everyone seems, or not everyone, but there seem to be a lot of media resources that have endless stories upon stories upon stories, and there's lots of anecdotal ideas on where to go from there. I guess one of the things that I did find, there's not a lot of research per se on the subject. Isn't exactly the kind of thing you would do a trial on or anything like that. It doesn't really, it's not really appropriate, but there was a survey that I was reading about that they did in Belgium, and they did it of pediatricians and asked them what their thoughts of medical assistance in dying for informed minors, and meaning like children that in adolescence that were terminally ill or faced with illnesses that were causing huge difficulties in their quality of life and their families, and then kind of what their opinions on that, on providing that service was. So, I mean, I'm not going to have time to go through the whole study with you today, but I can give you that resource and you can read through it. But some of the highlights that I read that I thought were interesting were opinions based on what they had experienced as clinicians. So for myself, being a first-year resident, I haven't really experienced a patient that was in that situation yet, but some of the things they said were that they wish they would have had it as a resource. So they wished that people would at least have talked about it So I think we're at a little bit of a crossroads in Canada now where I think it's becoming more of a discussion point. Yeah, so I'll leave you with that paper to read. I also did a bit of a search on some children's books that make it a little bit more digestible for children who are curious about death and dying and terminal illness. And so I'll give you a list of those too. There's some interesting ones that are for different levels that you can kind of talk about with your children. Yeah.
That's great. Great. Feedback. Karen, yeah.
So I wasn't quite sure, I wasn't quite sure if Candace had come in because her kid had like brought up dying or this was a terminally ill child. And so I
don't think I was really
okay,
sure.
Because depending on the process, I think when you came in, you set the scene very well in terms of what you were going to talk about. And then it was a complex topic that couldn't be covered in 5 minutes. And sort of set the expectation of the parent and made sure that anything that they wanted was going to be covered. But my first impression was that this was a parent of a terminally ill child, and when you got nervous, you smiled a little bit.
That wasn't where I was coming from in the situation. I thought it was just, maybe I shouldn't get that word there. I don't think it was clear to me, really, the question. But my understanding, I guess it was a little bit ambiguous anyways, was that it was a parent who was discussing death and dying with her children, not that they were deathly ill or considering, but like just as a general topic in a pediatric clinic where kids are curious about death. But yeah.
So that changes, I guess, the tone was a little bit more upbeat than if I had gone in thinking. But if that was your intention of the situation, then that's fine. I think initially, or I guess as it went on, there were very good explanations of what the topics were. I guess I just like write down technical terms, and you explain, like informed minor, you did explain going forwards. But yes, overall I think it was a very good job. My improvement is no longer valid.
No, I think it is. I think it should be more clear.
Yes, we need to frame the questions a little bit better.
Yeah, we can do that. We can do that for sure. So parents are coming in asking a question. You know what question you're trying to answer. What the point of this 5 minutes? Last year we didn't. I didn't do this session last year, but we didn't have a parent there, so you were kind of more presenting to the class about the topic. But this is much more real. Really, in the sense of that. I mean, obviously you probably will present to your class at some point about something. But okay, let's get some feedback from someone else. Probably you get a break, but okay, go ahead.
Really good job. I really like that you set the tone by saying this is a really broad topic, and that it's not only that you probably won't be able to cover everything, but that you're available for further discussion, which I think is important. If you're just going to drop the ball and somebody can walk away, it's like, where do they go after? And I thought it was interesting that, you had this topic that was about like assistance in dying in children, which is not legal here, which then makes your search a little bit more complicated, but you also had the resources just about death and dying in children and kind of offering that as kind of almost like a secondary topic. I don't have a ton of constructive criticism. I think it was
What did you search? Interested in how you decided to search for this, because that's not something I would be like, oh, the medical literature is necessarily the best place to go for an answer.
I went on CBC, honestly, and went by the most recent articles, to be honest. And then I did also I went through Ovid, and then I did child, and then medical, and then dying or something, and then I found a couple of articles. One was from what did I say? I forget now.
You did say a lot.
Yeah.
One thing to be aware of. But I think you probably did it because it was a difficult topic and difficult to know how to transition and what to talk about, but just...
I do the same thing, except instead of saying I say, okay, great. Real hot water. many situations, so I've tried to do my best when like pausing is good.
We had communication sessions in med school where we were always with the same 4 people, and then one guy in our group would always say "awesome" as like the translation word. So
Yeah, no, I say a lot. I need to work on that.
Yeah,
I didn't notice.
oh,
You're okay with the good feedback or good eyesight and communication. So nothing. Very hard topic, I'm sure to
Doing.
Yeah.
That's a challenge. I agree with everything. You seem very comfortable, and considering it was a difficult topic and kind of a tougher one, you seem relaxed and eager to share. Great.
Options for resources.
Yeah, I know. Okay. Thanks, guys. Excuse me, who wants to be next?
Make Jonathan last. After you put your hand to go first.
I really.
You can go next.
Okay, cool. Alright. Hi, my name is Linda. I'm one of the residents. So first of all, 37 weeks pregnant. Congratulations. So I understand you're here to talk about your positive swab results from last week, right? And what that means for your baby and what we can do about it. So when we did the swab last week, the thing we were testing for is something called Group B strep, which is a bacteria that's kind of in many people's kind of genital tract, like around 20 to 30%. And the worry with that is always that when women give birth, that the bacteria might get passed to your baby, and because babies, their immune system isn't really developed yet, that it can give them a bad infection. And so what we usually do currently is for every woman with a positive result, we end up giving antibiotics at the time of their delivery, and that actually works pretty good. It has reduced the rates of Group B strep infections in babies by many folds since we started giving the antibiotics. So that's something really reassuring, right? And I know the other thing you're wondering about is whether there's a vaccine for it, right? And so that's something that's currently under development. Actually, I had to look this up myself as well, because it wasn't really something that we had talked about before. So what they found right now is that a vaccine would really help in terms of further reducing the chance of passing on that bacteria to the baby. But we haven't really found a safe one, or a vaccine that would be really that would really work well in terms of preventing all types of the Group B bacteria. So that's something that's unfortunately still under development. But hopefully something that will come out in the next couple of years. So right now what we can do is when you come into the hospital for the delivery, we'll give you the antibiotics, and that should hopefully reduce the chance of passing on the bacteria to the baby. Do you have any other questions or did that make sense?
What kind of sicknesses that can come out of baby getting?
So the more common one is babies, when they get an infection, they can go into their blood. So they might get really tired, they might get really lethargic, hard to wake.
and they might not want to feed. They might have a fever, or they might get cold. That's kind of their response to getting infection as well. So they might show different sorts of symptoms. And in that case, if the babies do have the infection, we give babies the antibiotics as well. And most of them do have pretty good outcomes from just getting the antibiotics as long as we catch it early as well.
So what are some pre-tests of catching in order to catch it too, for sure?
Pardon?